The A to E assessment approach is crucial for systematically assessing Mr. David Nasal, who is presenting with an acute exacerbation of chronic obstructive pulmonary disease, which in shorter term is known as COPD, complicated by his COVID-19 infection. So let's walk through each stage of the A to E framework to inform clinical decision making. So first we have airway. David's airway is currently patent, meaning he can maintain his own airway. However, this does not rule the potential for airway compromise due to worsening respiratory distress, especially considering his significant COPD exacerbation. This article explains that COPD includes chronic bronchitis and emphysema, which means there is impaired airflow into the lungs. COPD is characterized by irreversible airflow limitation due to narrowing and obstruction of the small airway, which leads to deterioration of lung tissue. This then results in hyperinflation of the lungs, which we can see on the chest x-ray. Hyperinflation occurs as the alveoli that is damaged traps air, which then leads to expiratory flow and increased lung volume. This then leads to barrel chest as chronic hyperinflation of the lungs due to COPD, as the anteposterior diameter is increased. Even though Mr. Nasal's airway is patent, the yellow sputum, a sign of infection, presents a risk of airway obstruction. Therefore, it is important that continuous monitoring of his airway for any signs of compromise, such as increased mucus or decreased airway, is crucial. David's respiratory rate is elevated at 30 breaths per minute, which is known as tachypnea, which shows that David is suffering from respiratory distress. His SpO2 is critically low at 78% room air, far below the target range of 88 to 92%, indicating severe hypoxemia, which is low partial pressure oxygen in the blood, which is seen in his ABGs as his PaO2 is 55 mmHgs, triggering peripheral chemoreceptors in the carotid and aortic bodies, triggering the respiratory center to increase respiratory rate. This also shows that David is also suffering from hypercapnia, which is elevated levels of carbon dioxide PaCO2, 60 mmHgs, triggers central chemoreceptors in the medulla, which also causes increased respiratory rate. Furthermore, the use of accessory muscles, diminished breath sounds, wheezing, and crackles in the lung further confirms significant respiratory compromise. Moreover, the destruction of alveoli tissues and the resulting VQ mismatch, which occurs where there is uneven distribution of air and blood in the lungs, leading to areas where ventilation is insufficient for the amount of perfusion and where perfusion is inadequate for the amount of ventilation. David's cardiovascular system shows signs of being affected by his respiratory distress. His heart rate is elevated at 128 beats per minute, which is sinus tachycardia, likely compensatory due to hypoxia. Increased heart rate is aiming to deliver more oxygenated blood to the tissues. His blood pressure is elevated at 168 over 85 mmHg, suggesting a stress response to respiratory distress and infection. Additionally, his capillary refill of 3 seconds indicates delayed peripheral perfusion, a consequence of poor oxygenation. The high neutrophil count and CRP level, 25 mg per litre, points to systematic inflammation response likely due to the underlying infection. David's Glasgow Coma Scale score is 14 out of 15, indicating mild confusion and distress. This could be due to hypoxia and hypercapnia, both of which impair cognitive function. His altered mental status is another sign of the severity of his condition, as COPD exacerbations can lead to CO2 retention, causing confusion and drowsiness, as well as his elevated pH, which indicates respiratory acidosis, where carbon dioxide buildup reduces blood pH. David is febrile, which is an elevated temperature indicating a systemic infection likely exacerbated by COVID-19, along with a productive cough and elevated white blood cell count. The CRP further supports the presence of inflammation, further exacerbating his COPD. By interrogating these findings, we can prioritize interventions to address the most immediate threats to David's health, his compromised breathing, oxygenation, and infection by carefully monitoring, proving timely administrations of medications, and addressing his respiratory distress will improve his outcomes. Controlled oxygen therapy is important in avoiding hypoxemia. COPD exacerbations can lead to extreme hypoxemia. By maintaining oxygen levels of 88 to 92% ensures that tissue and organs are provided with adequate oxygenation, which will further prevent organ dysfunction and respiratory distress. It's also important in reducing the risk of hypercapnia. This is because if COPD patients are over-oxygenated, it suppresses the drive to breathe, which can lead to CO2 retention and respiratory acidosis. Regular administration of salbutamol every 2 hours and ipratropium every 6 hours is another high priority intervention. These medications work as bronchodilators to relieve bronchospasms and reduce airway resistance. By improving airflow and reducing work of breathing, by dilating the bronchial muscles, they alleviate wheezing and improve oxygen delivery to the alveoli. Prednisolone at a dose of 40 to 50 milligrams daily will reduce the airway inflammation caused by the acute exacerbation of COPD. It decreases mucosal edema, suppresses the immune system response, and helps control the systemic inflammation reflected in his CRP levels. Corticosteroids are a cornerstone in managing acute exacerbations as they prevent further deterioration of lung function. However, Mr. Nasal needs to be aware of the long-term use of corticosteroids and can only use in short-term intervals while monitored for peak effectiveness. Spirometry is a standard diagnostic tool for assessing lung functions in COPD patients. Spirometry provides information on lung capacity and airflow and measures the volume of air a patient can exhale after a deep breath and the speed at which air is exhaled. This can help provide initial diagnosis confirmation as it can confirm COPD by showing the presence of airflow obstruction. Spirometry can also track changes over time by completing regular spirometry tests. It allows for monitoring changes in Mr. Nasal's lung function, which helps in indicating if his COPD is getting better or not. When administering oxygen therapy, it is important to monitor for potential side effects like oxygen-induced hypercapnia. COPD patients can be at risk of CO2 retention if given too much oxygen. Therefore, careful titration to maintain oxygen saturations within the range for COPD patients of 88 to 92% is important. Continuous pulse oximetry is needed to monitor his oxygen levels, and arterial blood gases should be taken every 4 hours to monitor his CO2 levels. Salbutamol is a beta-2 agonist that acts as a bronchodilator, relaxing the bronchial muscles. Nursing considerations include monitoring for tachycardia and tremors, which are common side effects since David is already tachycardic. It is important to balance the benefit of bronchodilators with potential worsening of his heart rate. Nebulized salbutamol should be administered using a high-flow oxygen system, and its effectiveness should be monitored through improvements in his respiratory rate and breath sounds. Ipratropium is an anticholinergic bronchodilator used to reduce bronchospasm. When administering this medication, nurses should monitor for dry mouth, urinary retention, and dizziness, which are common side effects. Like salbutamol, it helps improve airflow without the tachycardic side effects, making it particularly useful in cases like David, where heart rate control is important. Prednisolone is a corticosteroid, so monitoring for side effects like hyperglycemia, gastrointestinal upset, and increased susceptibility to infection is necessary. Given David's risk of infection due to COVID-19, careful monitoring for any worsening of infection or signs of opportunistic infection is crucial. Nurses should administer this medication in the morning to mimic the body's natural cortisol rhythm and reduce the risk of insomnia. Azithromycin is a macrolide antibiotic, and nurses must be aware of its side effects. These include gastrointestinal upset and potential QT prolongation. Since David will be receiving it intravenously initially, it is important that careful monitoring of his cardiac rhythm through ECG is necessary, especially considering his pre-existing tachycardia. Ensuring that Mr. Nasal is adequately hydrated can help in reducing gastrointestinal side effects of the antibiotic. The combination antiviral therapy for COVID-19 requires monitoring for liver enzymes elevation and gastrointestinal side effects such as diarrhea and nausea. Nurses must make sure that the medication is administered exactly as prescribed, as deviations from the dosing schedule can reduce its effectiveness. Moreover, monitoring liver function and ensuring patients remain well hydrated is very important in preventing toxicity.